Very good morning to one and all, and let me set the ball rolling by presenting a interesting case, a case of acute reversible LV dysfunction in a patient. Our patient, 65 years old female, who presented to us with acute onset chest pain, fatigue and breathlessness of 12 hours duration. And the past history is unremarkable. She presented with a blood pressure of 100/65 and heart rate 110, and no gallop rhythms, but bilateral basal crepitations. And this is the ECG you can see. You have interval MI, ECG showing suggestive of interval elevation MI. And you can see that this is a parasternal long axis view showing hypokinetic interval, not clearly seen in this view, but you can see the basal septum and the basal IVS, and the basal IVS and valves are very hypercontracting. And in this view, you can see there is hypokinetic, severe hypokinesia of the interval, anterior septum, and apex also. So you can see here, except basal segment of the LV, all segments are hypokinetic. There is hypercontraction of the basal septum, and also there is also a possible evidence of systolic anterior motion of the mitral valve. It comes and touches the interventricular septum for a few fraction of a second, and there is a mild LVOT turbulence is also seen. And you can see there is a SAM, not severe SAM, it's only a mild SAM occupying in the early part of systole, and turbulence seen in the LVOT. And there is also a mitral valve regurgitation is present, a moderate regurgitation of the mitral valve. And LVOT gradient around 30 millimeter of mercury. And this patient was catheterized, and it was tended to be normal, and going into the cardiac enzymes, it was tropi was elevated, whereas CPK is around 20, BNP is 890. So the hospital course and treatment, she was treated with antiplatelets, heparin, ACE inhibitors, diuretics, beta blockers, and IV fluids were given. There was hypotension, but we gave IV fluids gradually to as there was LVOT obstruction and HOCM in a patient with HOCM. We gave some amount of fluids, thereby she gradually recovered. And you can see this is after 4 days. You can see the nicely contracting LV. And the LV function is gradually improved over the period of 1 to 2 weeks and become normal. And this is echo after 4 days of admission. You can see a nicely contracting LV. So this is on discharge. And there is almost very minimal, no turbulence and no SAM. So our conclusion was a case of acute stress-induced cardiomyopathy, a form of primary acute cardiomyopathy. Going into history about the presence of LVOT obstruction, it is occurring in around 10 to 25% of patients with stress cardiomyopathy, and we should keep in your mind, because if you patient present with hypotension and stress cardiomyopathy, if you give inotropic support, it can aggravate the LVOT obstruction and more hypotension will pursue. So better these patients should be cautiously judged, and if you give intravenous fluid, and ACE inhibitor should not be given, and to avoid reduction of afterload. So this form of acute reversible LV dysfunction, this is secondary to excess release of catecholamine due to stress, which can be a physical or mental stress, leading to stunning of myocardium. It usually recovers within 2 to 4 weeks, but complications like cardiogenic shock, congestive heart failure, and death can occur in the incidence of 6.5%, 3.8%, and 3.2% respectively. LVOT obstructions is not common. It occurs in up to 10 to 25% of patients. And so these are the various types of cardiomyopathy now reported, even though the classical form is apical ballooning syndrome or apical cardiomyopathy. Now stress cardiomyopathy has also been reported to involve only the mid-ventricle or sometimes even basal and focal. Only the apical form is considered as the Takotsubo cardiomyopathy, but this is the other types which we are encountering. We have seen one few cases of basal cardiomyopathy in a patient where apex is completely contracting, that is hypercontraction, where a base is totally akinetic. So management is, as I said, we should give fluids. Sometimes we need fluids. A routine use of inotropes in patients with hypotension should be very cautious. Thank you.